Good morning. We are going to talk about antidepressants today. Before going into the topic proper, let us first discuss depression. The theory of depression mainly deals with monoaminergic hypothesis, as well as the other theory is of BDNF deficiency, brain derived neurotrophic factor deficiency. We have to talk in detail about monoaminergic. What does this theory of depression tell us? There will be a deficiency of either serotonin or norepinephrine in a case of depression. So what usually happens is, whenever a presynaptic neuron is excited, it releases the neurotransmitter. It can be either serotonin or norepinephrine. Whatever neurotransmitter is released usually has three fates of this. The first fate is to act on the postsynaptic receptor. Second fate is to get metabolized by monoamine oxidase enzyme. Third fate is to get reabsorbed back into the presynaptic neuron so that it gets stored in the vesicles. Now, in a case of depression, what usually happens is there will be either deficiency of the serotonin or norepinephrine. So, what our treatment goal here will be is to increase either release of norepinephrine and serotonin, or to reduce the metabolism of norepinephrine or serotonin, or to reduce the reuptake of norepinephrine and serotonin. Considering this as our treatment goals, there are various drugs which can be used. Based on this, the first point, based on to reduce the metabolism of norepinephrine and serotonin, the usual enzyme which metabolizes them is called as monoamine oxidase. So, the first group of drugs which are used for the treatment of depression are monoamine oxidase inhibitors. Second group are reuptake inhibitors. Based on our treatment goals, these will be reuptake inhibitors. Third will be miscellaneous. So, let us first start about our monoamine oxidase inhibitors. Monoamine oxidase is an enzyme which is primarily used for the metabolism of norepinephrine, serotonin, and various other monoamines like dopamine. These monoamine oxidase is of two types, MAO-A and MAO-B. MAO-B is primarily for dopamine metabolism and use is found in Parkinsonism. Drugs which modulate MAO-B use is found in Parkinsonism. MAO-A inhibitors are primarily, right now we use them in depression, and there are many, but right now we restrict ourselves to REMAs, that is reversible inhibitors of monoamine oxidase. So, REMAs drug include moclobamide. This is a reversible inhibitor. Why is it so important that we tell that it is a reversible inhibitor? Previously, there were many irreversible inhibitors and they caused a lot of life-threatening side effects. So, in a case of reversible inhibitor of monoamine oxidase, the drug or the enzyme is inhibited only for a short duration of 2 to 3 days. And even when we take REMAs, when the patient is on REMAs and if he consumes any food which is very rich in tyramine, the patient ends up in cheese reaction. What do I mean by cheese reaction? Tyramine acts as it replaces norepinephrine, and Whenever remas are not, whenever the patient is on rema, this thiramine will not be metabolized, and norepinephrine will be uncontrollably released on appropriate stimulus, resulting in hypertension crisis and is life threatening. This hypertension crisis is of very less intensity in the place of when we use remas, and it is of very high intensity for the previous drugs which were irreversible inhibitors of MAO. Now let us talk about our second group, that is reuptake inhibitors. Reuptake inhibitors, from the point one, we were talking mainly about norepinephrine and serotonin. So basically, these reuptake inhibitors are also classified as tricyclic antidepressants, which inhibit the reuptake of both norepinephrine and serotonin. First one. Second group is SSRI, selective serotonin reuptake inhibitors. These primarily inhibit reuptake of serotonin. And the third group is SNRIs. These are primarily, they inhibit reuptake of both norepinephrine and serotonin. So once we will see what is the reuptake mechanism. See, this is our presynaptic neuron. This is our postsynaptic neuron. On appropriate impulse, serotonin and norepinephrine, which is stored in the vesicles, is released into the synapse, which primarily acts on my postsynaptic receptors, so that my postsynaptic neuron is excited. What usually happens is this gets reuptake by certain transporters. They include SERT, serotonin reuptake transporter, clear, as well as the other one is this is SERT, which primarily inhibits the reuptake of serotonin, as well as there is another transporter which is primarily used for the reuptake of norepinephrine. Now our TCAs inhibit both SERT and norepinephrine transporter. So TCAs inhibit both norepinephrine and serotonin reuptake transporter. But the major problem with TCAs is they lack that specificity to act only on serotonin and norepinephrine. In fact, they also cause H1 blockade, H1 antihistaminic blockade, because of which they cause sedation, and they also have action on alpha 1 receptor of of adrenergic system, the alpha 1 blocker, resulting in postural hypotension. They also have they also have prominent anti-muscarinic action, because of which these drugs also cause lot of side effects like dry mouth, constipation. These drugs are also known to they also have pro-arrhythmic potential, mainly because of their action on potassium channels. They also have pro-arrhythmic potential. One more major problem with them is all TCAs have this tendency to cause precipitate seizures. And TCAs also have very narrow therapeutic index. Because of all these, we started searching for better and safer drugs. There comes our SSRIs, selective serotonin reuptake inhibitors. TCAs include a wide variety of drugs like imipramine, amitriptyline, nortriptyline, trimipramine. Now, SSRIs. SSRIs, they primarily inhibit serotonin reuptake only, and they have lot of advantages over TCAs. Most important advantages include: first thing, no H1 antihistaminic blockade, no antimuscarinic action, no antimuscarinic action. Third one, no alpha 1 blockade. They are relatively safer drugs. No antiarrhythmic potential. They have almost zero tendency of precipitating seizures. These all are advantages of SSRIs. Because of all these, SSRIs are now considered as better drugs for treatment of depression. Then let us talk about SNRIs. One major problem with SSRIs was they were very good, but efficacy was relatively on the lower end. So they started developing newer drugs which mainly inhibit both serotonin and norepinephrine reuptake inhibitor, but without any action on all these, like your antihistaminic, alpha 1 blockade, antimuscarinic effects. These drugs include your venlafaxine, desvenlafaxine. These drugs are primarily used in the treatment of resistant depression. Sorry to mention, SSRIs drugs include fluoxetine, fluoxamine, sertraline. Fine. Now let us talk about certain. See, till now we spoke about drugs are second goal, that is reuptake inhibitors. Now we will talk about all those miscellaneous groups. In fact, we label them as atypical antidepressants. These atypical antidepressants are of various mechanisms. One such thing is, certain important mechanisms are, with respect to trazodone, it is basically a SARI. What I mean by that is, it is a 5-HT2 serotonin antagonist as well as reuptake inhibitor. This is primarily used in the treatment of impotence with depression. Then comes our NASA drugs, which includes mirtazapine. Mirtazapine primarily is a noradrenaline and specific serotonin antagonist. What I mean by this is, mirtazapine primarily blocks alpha 2 as well as presynaptic 5-HT receptors, so that release will be increased. Then comes our third atypical antidepressant drug, mainly norepinephrine and dopamine reuptake inhibitor, bupropion. This is primarily a norepinephrine and dopamine receptor reuptake inhibitor. This is used in smoking cessation. Then comes our fourth one, Or your final one, in fact, final atypical antidepressant, vilazodone. Vilazodone is primarily a SPARI. What I mean by this is serotonin 5-HT1 partial agonist, 5-HT1A partial agonist, and also a reuptake inhibitor. Clear? So these are our atypical antidepressants. Now we will talk about uses of antidepressants. Obviously, most important use is depression. For any endogenous depression, we have to treat them with antidepressants. SSRIs are considered as first line drugs. In a case, SSRIs are first line drugs. In a case of resistant depression, SNRIs are used. In a case of depression with impotence, as discussed earlier, depression with impotence, usually trazodone is preferred. In a case of elderly person with depression, we can use REMAs because these are cardiovascular safety is proved for these drugs. This is with respect to depression, the main first important use of antidepressants. Second use of antidepressants is your nocturnal enuresis. With respect to nocturnal enuresis, imipramine is the drug of choice. With respect to neuropathic pains, these are third use of antidepressant drugs. Neuropathic pain, imipramine, amitriptyline, nortriptyline are preferred. Then comes our fourth use, that is migraine prophylaxis. For migraine prophylaxis, antidepressants like amitriptyline and nortriptyline are preferred. Now, bupropion is preferred for bupropion is used in smoking cessation. And then we also know about certain drugs like certain conditions like ADHD. Atomoxetine, which is a part and parcel of antidepressant, can be used, but right now we have wonderful drugs for them. And certain TCAs can also be used for pruritus, but we rarely use for these. Now we will talk about adverse effects. These are the uses of antidepressants. Now we will talk about adverse effects. First, adverse effects of TCAs, because there are a lot of other receptors which are being modulated by TCAs. TCAs are known to cause sedation as well as arrhythmias as well as postural hypotension, and also your antimuscarinic actions like dry mouth, constipation, constipation and all. Fifthly, these drugs are also known to cause impotence, except for one drug, that is dortipine. It is known to cause less impotence, and trazodone is primarily used for the treatment of impotence, so we can use them. TCAs are known to cause some sort of sexual dysfunction. Fine. And they also precipitate seizures. These are the adverse effects of TCAs. Now we will talk about adverse effects of SSRIs. One most important adverse effect, see on comparison with TCAs, SSRIs are better drugs. The only adverse effects or prominent adverse effects we see are GIT, where it is because of the 5-HT3 receptor stimulation. They are known to cause some sort of nausea, vomiting, and all, as well as some loose motions, diarrhea, nausea, vomiting, diarrhea, and all. It also has some effect on platelets, because of which impaired platelet function is seen. Platelet, sorry, impaired platelet function is seen. This impaired platelet function is responsible for ecchymosis as well as epistaxis. One most important side effect of SSRIs is serotonin syndrome. Serotonin syndrome is usually seen with certain drugs like MAO inhibitors plus SSRIs. Or, this is the first combination. Second combination is tramadol with SSRIs. What usually happens is serotonin presence is more under the influence of these two drugs, resulting in prolonged duration of serotonin in the synapse, which results in lot of effects like restlessness, rigidity, hyperthermia, and rarely they may also cause your convulsions. These are with respect to SSRIs. Now, let us talk about the adverse effects of MAO inhibitors, where I have already discussed, which includes cheese reaction. We are more bothered about cheese reaction, and along with cheese reaction, there is proven cardiovascular safety is established. Rarely, some small issues like insomnia can be seen. I think I have concluded everything. Thank you for listening.